Hi, my name is Hern. I'm an emergency physician in California. I'm also an EMS physician. Today, we're going to talk about EMS-initiated buprenorphine training. I'm here to guide you through what I think is a life-saving and a job-enhancing novel approach to treating opioid use disorder. This training is going to provide you with some tools for implementing EMS-initiated buprenorphine and a comprehensive understanding of why this innovative work really matters. Today, we're going to hear from some really interesting people and topics. We're going to hear from Dr. Alicia Gonzalez. She's the Bridge Clinical Training Director and Implementation Leader for Bridge. We're also going to hear from Vanessa Lara. She is the EMS Bridge Project Manager and the Research Lead. Together, we're going to guide you through this material, which is designed to support EMS teams in the implementation of buprenorphine. We expect that this is going to lead to more fulfilling work for you and to your team, and to provide an opportunity to intervene in this crisis. Our project is part of the California Bridge program. It is a program of the Public Health Institute, and the Emergency Medical Services Buprenorphine Use Project is supported by the CareStar Foundation. We're going to talk about a few things today. We're going to talk about some of the background and the history of opioid use disorder and treatment in this country. We're also going to talk about how you can help and the EMS Buprenorphine Use Project and the protocols implemented to deliver buprenorphine in the field to patients who need it the most. We're also going to talk about how to engage with patients who have an opioid use disorder through motivational interviewing. And in the end, we're going to bring it all together and talk about some case studies and really help to solidify your understanding and knowledge of this topic. I'd like to introduce Dr. Alicia Gonzalez, who is an amazing emergency physician and a true pioneer in the educational field in this process. Thank you so much. Dr. Gonzalez.
Hi, I'm Alicia Gonzalez. I'm an emergency medicine doctor here in California and the clinical training director for the California Bridge program. And it's my privilege to be able to talk to you today a little bit about the history of the opioid epidemic, how we got here, but way more importantly, the basics of medication for addiction treatment, or treating patients who suffer from addiction with medication to help save their lives and help them live well. It's one of my favorite topics to talk about, so hopefully that comes through and we all learn something together in the process. Before we get started, I want to make sure that we level set just for a second so that when we say opioid, we're all talking about the same thing. Opioid is the correct term for the larger family of drugs and medications that all essentially stem back from this plant, opium. Opium-related products, whether synthetic or natural, cause euphoria, they cause sleepiness, they take away people's pain, they make you feel super relaxed, and they make people generally feel high. However, at higher doses, they can cause respiratory depression or even respiratory arrest, also known as overdose, which leads to death. How did our country end up in a place where there's truly an opioid epidemic with how many people are dying from opioid use disorder? And the answer is, it's complicated and multifactorial, and there are a lot of things that played in, but there are a couple of big ones. And one of them is that back in the 1980s, Big Pharma started putting out some papers saying that opioids were totally safe and effective, and that no one should ever have to be in pain, and we should be using these medications, quote, freely and without concern, and that, quote, they're not hypnotic, and there is no danger in acquiring a habit. I mean, really overselling the safety profile of these medications. And then at the same time, the VA and the Joint Commission, previously known as JCO, and then patient satisfaction surveys, all started pushing for this, like, pain is the fifth vital sign, must treat pain, must address pain, must get pain down as one of the biggest drivers in medicine. And so we saw a huge surge in using and writing prescriptions for opioids in the medical setting. In parallel, around the same time in the 90s, the Mexican cartels started really pushing heroin into the United States. And so black tar heroin made its way across the country, and now we had a huge amount of access to illicit heroin and opioid in our communities as well. In more recent years, we had things like the COVID-19 pandemic and general rising costs of life and all kinds of stuff, leading to both limited access to healthcare, specifically chronic pain management and mental and behavioral health services, as well as things like unstable housing, tons of skyrocketing rates of depression and anxiety ever since COVID. I mean, the world is in a really rough place and there's a lot going on for people. And so in the midst of all these economic and emotional concerns, people are driven to find other ways to cope and to deal with their circumstances. You put that all together in one giant bundle and you end up with the US opioid epidemic, which unfortunately has led to an incredible number of lives lost. This is a graph that you probably have seen before, and unfortunately just really makes visually obvious the rapid rate of rise, the number of people who have started to die from opioids comparing 1999 up to 2021. In fact, in 2021, over 100,000 people died from drug-related overdose. And of those 100,000 people, 80,000 of them were from opioids. So if you look at that in a different way, this is again showing you all drug overdose deaths. And you can see that the vast majority are from opioids. That's the black line at the top. And of those opioids, I mean, gosh, almost, what is that? 5/6 of them are from synthetic fentanyl. Fentanyl is now all throughout our communities. It's found clandestine in most other drugs as well. And it's a really potent, and it's definitely just increased the number of people that have unintentionally died from opioids. Said a different way, just to kind of give context to how many deaths we're talking about, in 2021, the number of people that died from opioid overdoses in that year was more than the number that died from car accidents and gun violence combined. That's an alarming number of people to die, and certainly not the kind of record that we're trying to be setting here. And as mentioned, we know that we in medicine were part of starting this problem and pushing opioids as our primary way to treat pain. And so thankfully, there's been a lot of work done to decrease those prescriptions, to work on using alternatives to opioids or Alto in the treatment of pain. And that's really great. I mean, our work in prevention is certainly not done. But unfortunately, as this graph shows you, despite a significant reduction nationally in the number of prescriptions, so the shrinking little purple graph at the bottom, despite those efforts, the number of deaths continues to rise. That's the blue bar growing on the top half of this shelf. And the reason why is because illicit fentanyl has led to a massive increase in fatal overdoses. And we cannot stop that by curbing our prescription writing. While it's obviously a really sad and a bleak picture, the good news is that there is a light, and the light is named MAT, or medication for addiction treatment. You may have heard it as medication assisted treatment. That was its previous term. But MAT is critical in treating patients who have opioid use disorder specifically. And to be able to do that, we first have to acknowledge what science has overwhelmingly already showed us, which is that substance use disorder, addiction, is a medical neurocognitive problem. When we use opioids, it triggers a huge dopamine surge in our body, and that is what our body gets addicted to. Drugs cause a very powerful feedback loop, and it just drives us to do the same thing again and again and again. But it doesn't mean these are like bad people or not worthy of care, that they're doing this like quote on purpose or deserve any of the negative consequences that are happening to them. People choose to cope in all kinds of different ways. I mean, compare this to like unprotected sex or risky sex, or eating fatty foods or not getting enough exercise. If you do that, you can end up with obesity and diabetes. But we don't withhold insulin from you because you made poor dietary choices. We give you the medications to help treat these consequences of your choices, but now chronic disease. In addiction, it's the same. Not bad people, unfortunate choices with lasting severe consequences that thankfully do have treatment options. And that is the key here. Why do we need medication anyway? Well, remember that some drugs, as you use them over time, you can build a tolerance, right? So if you take an opioid pill every single day, over time, that same pill will not give you the same effects that it used to unless you take extra. Once you develop enough tolerance, your body starts to become dependent, meaning that when you don't have opioid in your body, you can't feel normal. You go through withdrawal, which is horrific and painful and terrible, and would absolutely drive any rational person towards seeking out opioids again to stop that pain and to stop that process. So MAT honors that for a person who has opioid use disorder to feel normal, for their brain to feel stabilized and be able to function, they need to have a little bit of opioid replacement in their system. Not only does MAT make people feel better, though, we know evidence shows it does save lives. If the general population's risk of death over 5 years is, let's call it 1, we know that patients who are using opioids not in treatment have a 6 times higher risk of death than the average person. But if you get that person on MAT, their risk of death comes down to less than 2 times the general population. That's a giant reduction in mortality, one of the most impressive mortality reductions of any medicine that we have. But it tells you that number 1, OUD, opioid use disorder, has a really high mortality risk. But number 2, the treatment, MAT, has an incredible ability to save lives and reduce mortality. Why is this an acute care problem for like a paramedic or an ER doctor or a hospital? Like, why are we worried about this? Because when they looked, this is a study from the East Coast, when they looked at patients who had just overdosed on naloxone, or excuse me, had just overdosed on opioid and been resuscitated by naloxone, either pre-hospital or in the hospital, that the risk of death of that population was really high over the next year. And that makes sense to me, right? Like that person just died and we gave them naloxone and they lived. And so it makes sense to me that they would be medically really vulnerable. But what we know is that of the people who die in that year, 20% of them are going to die in the first month. And of that group, 20% die on the first 24 to 48 hours. So that big blue spike you see in this graph is showing you that the highest rate, the highest risk of death is in the next 1 to 2 days after that overdose. So every time that we resuscitate a person with naloxone, that person is incredibly medically vulnerable, and we have an opportunity to intervene and save that life. And while we know those moments are so critical, historically, there have been way too many silly barriers preventing us from doing this work. And so part of making a medication first strategy work is making it a easy to access low barrier entry. For example, we do not exclude patients who are using other drugs. You use opioids and meth and alcohol, whatever. I'm still going to treat the opioid use disorder part of it with MAT. We don't require long intake questionnaires or routine urine toxicology screenings. Those things might have a place in ongoing care to help, providers in the outpatient setting monitor compliance with treatment plans and blah, 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 but certainly not to access care, right? We're just going to start the medicine, save the life, stabilize the brain. We don't mandate things like participation in NA or group therapy. While those things have been shown to help certain patients, they don't always help everybody. And it shouldn't be a precursor to keep you from being able to get the care that you deserve if you don't do those things. We also don't demand people going cold turkey, right? Start the medicine. Just start the medicine, save the life. This is similar to me, like if you have a diabetic and their new diabetes and their blood sugar is really high. Can you imagine if their doctor said, yeah, so here's what we're going to do. Your sugar's like 500, but you know what? For 6 months, I want you to diet and exercise. You're going to go to this like group teaching clinic where they do how to make healthy foods class, keep a food diary. And like at 6 months, if you're doing a good job, then you can have insulin. Are you serious? No, but don't do that because the insulin is critical and saves a life. Same here. Buprenorphine, MAT, whatever, it saves lives. So we got to get our patients on medication and take those barriers away. The goal, again, is a low barrier medication first treatment. MAT reduces cravings, it stops withdrawals, it prevents overdose, but it does not matter how good our treatment is if it's not in anybody's body. We want to get it into our patients, rapid, same day, low barrier, get those people on medication and increase the number of lives that we're able to save in the process. When we say MAT, we're generally talking about 3 different medicines, more so the agonist side of things. So on the left-hand side, you can see methadone. Methadone is a full agonist opioid, maybe the more common one that you're used to hearing about. It has to come from an OTP or an opioid treatment provider. People have to go to a quote methadone clinic every day, but it's a really good medicine. It does work. It is evidence-based. Naltrexone is an antagonist. It's a deterrent-based medication. If you have it in your system, the idea is that the opioid that you take wouldn't work. And then buprenorphine in the middle, we're going to spend a lot more time talking about for some practical reasons. But before we move forward, I want to emphasize that is not to knock the other meds on this screen, especially methadone. Methadone is a good medicine. It saves lives. It is evidence-based. And if a patient is doing great on methadone, we want to leave them on methadone, okay? But for some practical purposes, buprenorphine is a really good choice, maybe the better choice for a lot of us in acute care. Buprenorphine comes as an oral dissolvable tablet or film. There are also some injectable versions, but generally we're talking about the oral version. You have to let it dissolve fully in the mouth. It does not work the same if you swallow it. So help them get a little water, wet that mouth, get the medicine in, let it dissolve. no food or drink for like 15 minutes to get that medicine all the way absorbed. It does not have the same bioavailability in the stomach. It can come as plain buprenorphine or combination bup naloxone. A common brand name for that one is called Suboxone. I don't say that for any financial reason, but our patients actually call it Suboxone a lot. So I want to make sure you know that term. So they'll call it buprenorphine or bup or boop or Suboxone or Boxin. They call it all kinds of stuff. But we're really talking about buprenorphine as a family. The idea behind the combination tablet is that the naloxone is supposedly inert when you take the medication appropriately, but that if you were to try to not use buprenorphine appropriately, if you were to try to illicitly use it or inject it or something, that the naloxone would keep you from being able to get high. I'll be honest with you, the short version of this is it doesn't matter. Plain bup, combo bup, I don't care. It all works really well. Some patients don't tolerate the combo pill very well. It gives them GI upset. So if they want the plain one, just give them the plain one. They're both really safe and really effective. We like buprenorphine because unlike methadone or fentanyl or morphine or whatever, it's a partial agonist, meaning instead of turning that opioid receptor all the way on, you're only turning it part of the way on, enough to keep you from withdrawing and feeling terrible, to get that opioid in your system since you're dependent on it, but not to get high. And because of that, it also carries with it a ceiling effect for respiratory depression. You can't really overdose on buprenorphine alone. There is no upper limit to the dosing. You can go very, 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 very high, but those high doses are not going to cause overdose by themselves. Sure, in combination with other things that can make you stop breathing, like if you did, buprenorphine and some fentanyl and some alcohol, could you overdose? Yeah, of course you can. But bup by itself is a very safe medication. It has a really high affinity for the receptor. It will block other opioids. So if you have bup in your system and you use fentanyl, the fentanyl will not get onto that new receptor that the bup is on. The bup will hold on tighter. That's one reason you have to be in withdrawal before you can start taking bup. Because if you're high on like fentanyl and you give bup, it's going to knock that fentanyl off and bring you down. That's called precipitated withdrawal. It's not dangerous, but it feels pretty terrible, and we don't like that. So we wait for the patient to already be in withdrawal, and we bring them back up to normal by giving buprenorphine. It has a very long half-life. Most patients take it about once a day to stay in on MAT. And it kicks in within about 15 to 20 minutes, reaching peak effects at somewhere around 1 hour. When we look at methadone compared to buprenorphine, this is kind of a summary slide of all those differences, but the main benefits of bup, again, are that you don't have to go to an OTP. You can have a take-home prescription. It doesn't cause respiratory depression. It doesn't cause altered mental status. You can drive a car. And both of them, I want to point out, are safe in pregnancy and breastfeeding. Really important point. So the American College of Obstetrics and Gynecology also supports the use of MAT in pregnant and breastfeeding women. Certainly better for mom and baby than illicit drugs are. A couple of other FAQs. Patients do not have to start bup in the hospital. It is so safe that if they're not in withdrawal right now, they can do a take-home self-start prescription for when they are in withdrawal at home. Super safe med, does not require admission, even for pregnant patients. It is safe in minors. It is approved for 17 and up. It's been used off-label from 12 to 17 years old as well. Continues to be proven safe and effective, but we do get into some consent issues there. We won't deep dive into that right now, but generally, yes, it is safe and effective. Should I be worried about diversion? Short version? Not really, because it's cheaper than buprenorphine on the street? Fentanyl. It's easier to find? Fentanyl. It makes you feel really high? Fentanyl, exactly. And so bup is none of those things. We know that when patients are buying buprenorphine on the street, they're often trying to self-treat withdrawal, to do something, to go to a graduation, to, take a flight somewhere, to go to a job interview. They're trying to self-treat. So the best way to prevent diversion is to make bup easy to find for people who need it to be in treatment. It's not the same as like methadone or other full agonists being diverted. I wouldn't let that be a fear of yours. The DEA is not raiding anybody's offices for starting too many patients on medication for addiction treatment. They're very supportive of us doing this work. If somebody already on buprenorphine is in pain, a really key thing to know, do not stop the bup. Leave it in their system. You can go up on those doses to help with pain management. You can add on top of it meds like fentanyl or hydromorphone or whatever. You can add meds on top, but we want to leave bup in their system. It's really important to help treat their pain. And then when should somebody come off of buprenorphine? Well, I'm glad that you asked, because the short version is probably never. When we look at what happens if you take people off of bup, very obviously, I think this wouldn't surprise anybody that the more you taper their dose, the more likely they are to return to illicit use because their body still has dependence on opioid, right? To feel normal, they need their medication. This is like saying, when does a patient with diabetes come off of insulin? Sometimes they will, but most of the time they don't. They need insulin for forever because the physiologic changes in their body require exogenous insulin, medical insulin, to stay normal. Same is true for patients who have opioid dependence. They will require that baseline opioid in their system to feel normal. And in fact, coming off of buprenorphine is dangerous because you return to illicit use and you have a higher risk of overdose in that setting. So we don't want to worry about taking patients off of MAT. For now, we start them on it, get them in treatment, and then certain patients can navigate with their clinician whether or not they want to come off in the long term. But MAT is sobriety. They are sober by being on their medication. And that's a really important point. In addition to how important and awesome medications are, I do want to give a quick nod to something else, which is harm reduction. And when I say harm reduction, what I also really mean is living well. Because whether we like it or not, drugs are here to stay. And just like diabetic patients are going to, eat pizza and have donuts, and hypertensive patients are going to eat potato chips and not exercise, patients are going to use drugs. And so our job is to educate our patients so that they can be safe in making the decisions that they're going to make to help not ruin or even end their life in the process. Harm reduction really has two branches. That first branch has to do with reducing stigma. This is the moment for all of us to acknowledge that we have our own relationship to drugs, whatever your personal and political and maybe religious feelings or thoughts are about drug use. We do all have one thing in common, which is that we got into this work because we care for people and we want to help people feel better. And so we have to first acknowledge that people are people first, and they're not defined by their behavioral choices or their diagnoses. And one way you can do that, I can do that, we all can do that, is by focusing on what's called person-first language. We don't want to refer to our patients as the derogatory labels we have given them for so many years. Tweaker, junkie, meth head, whatever. All that is so inappropriate and rude and degrading, and not the way we should talk about our patients. Instead, it's a person who has opioid use disorder, or a person who is using fentanyl, a person who has attempted suicide in the past, not a schizo, not a druggie. We just have to really start thinking about people as people. And I promise you that using those words help the patient realize that you care about them, and it'll help you in your own heart remember what you're here to do, that you're really just trying to help somebody. A couple of other tips for talking to patients and trying to reduce stigma and deal with the long history of stigma we have brought to these circumstances with these patients would be, first, to normalize. Make sure the patient knows you're not singling them out. Hey, a lot of my patients use fentanyl. Do you happen to use fentanyl? Right now, I'm not saying you look like somebody who uses fentanyl. I'm saying this is common. Let's talk about it. Acknowledge the past. Look, I know it's not easy to talk about this stuff with the doctor. We're not always very nice to patients who use drugs. And I'm really sorry if you've had bad experiences in the past. But today, here's the part where you align. My goal is to make you feel better. You look like you feel miserable, and I hate that for you. I want you to feel better. Can I ask you some questions? Can we try this medication? Always ask instead of assume. And remember that not everybody is going to be ready for treatment today. So how can we help this patient live well, or think about how to live well, even if they don't want the end outcome that you want, which is no more drugs and beyond MAT? But we got to help our patients get there. A couple tools they can use. There are fentanyl test strips out there to try to find clandestine or hidden fentanyl in other drugs. What I will tell you is these products are getting a lot better over time, but they're still technically kind of hard to use. So I don't think that they're accessible to most patients. It requires a pretty decent health literacy level. There is some technique to it. They're not going to be perfect for everyone. They can only test drugs that have been dissolved. So pills have not been tested. Only dissolved powder can be tested. So it's just kind of a lot of work, but they are a good tool, and they are getting increasingly better over time. A way more accessible and awesome tool is going to be naloxone. To me, naloxone is the AED or the CPR of our generation. And I wish that naloxone was in the hands of every single person in America, but certainly every person who uses drugs or who knows somebody who uses drugs, because the illicit drug supply is not regulated. So you just don't know what's in it. You never know when fentanyl is going to be in somebody's drug. And frankly, the answer is these days, it always is. And so you want to be able to save somebody's life or have them be able to save their friend's life in the incident that there is an opioid, a clandestine opioid, or a somnolent kind of medication in that drug that they're using. We do have now some over-the-counter options for naloxone. And of course, you can always prescribe naloxone. The reality is that going to the pharmacy to get naloxone is not a popular choice. There's cost and stigma associated with that visit. And we know that only 1 or 2% of prescriptions for naloxone even get filled. The better option is to put it in people's hands. So if you don't know the details of a naloxone distribution program and wherever you're at watching this video, look into it, because there are a lot of options, especially in California. The state DHCS runs a free naloxone distribution program that you can participate in. If a patient is going to use a loan, sometimes our unhoused patients or patients who maybe, don't have friends and family, or certainly during COVID-19, a lot of people were at home using a loan. There's an amazing hotline I love telling people about called the Never Use a Loan hotline. And the way that it works is that you call, it's anonymous. You say your name and where you're at and what kind of drugs you're going to do. And they stay on the phone with you to make sure you don't overdose. And if you become unresponsive, they send EMS to you. So really amazing resource, completely free and anonymous, and anybody can use it. Everybody's got a phone, I feel like. So it's really helpful. And then finally, and this one might be a little bit more uncomfortable for certain people, but knowing how to talk to patients about using drugs. Can you, make choices that will help decrease the risks associated? Could you smoke it instead of injecting it, so you're not at risk of infection and, hepatitis and all that kind of stuff? Do you know how to use alcohol swabs and a tourniquet and not miss the vein? And do you know how to access sterile syringes? And, do you know all that kind of stuff, and how to get screened for hepatitis C and HIV? If you're not comfortable talking about all of this, that's okay. There's a website, the National Harm Reduction Coalition, and they have patient-facing materials that talks about all of this with them. So you can even do something as simple as say, hey, I wish you didn't do drugs, but if you're going to, I really don't want you to die or get super sick from them. So let me show you this website. I want you to look at some of their stuff to make sure that you're being as safe as you can. And that's it. You could save a life that way. As a quick recap, opioids are killing way too many people. And we know that addiction is a chronic, treatable medical disease, and MAT is evidence-based and saves lives. So we have to make a medication-first approach with low barrier access a huge priority in all of our work in acute care. Both buprenorphine and methadone are really effective forms of MOUD. They absolutely save lives. But buprenorphine is preferred for us in the acute care setting, just for a couple of ease of use and practical reasons. Finally, harm reduction, getting rid of stigma, helping our patients live well has to be a part of the complete puzzle for us. This model, doing low barrier access MAT and counseling patients on harm reduction, as well as dropping our stigma, this is the new standard of care. This is evidence-based, it is person-centered, and I don't think I have enough words to express to you how excited I am to have you taking on this work and joining us. And I just want to thank you in advance for all of the work that you will do to help our patients live well.
Thank you, Dr. Gonzalez. That was fantastic, and a really great overview about how we got here and what we can do in the crisis. So thank you so much. We do really appreciate it. Now we're going to talk a little bit about what you can do to help this process. We're talking now about EMS buprenorphine and how EMS can initiate buprenorphine in the field. But first, we're going to talk a little bit about background. We're going to talk a little bit about how we can help people in crisis and where this theory and where this practice actually started from. This is incredibly important because there are lots of people in EMS who we encounter in EMS who never make it to the hospital. They might sign out AMA, or they might go to a hospital that doesn't have a really active substance use navigator program, or has a ton of providers that are really comfortable using buprenorphine. So in those cases, it's even more important for us in the field to have a role in starting medication-assisted treatment for buprenorphine, because we know that if someone is in long-term treatment, their prognosis and their mortality goes remarkably lower. So first, we're going to talk a little bit about the background of MAT in EMS. This is initially based on the work of Dr. Carroll, Jerry Carroll, and others out of Camden, New Jersey. The state of New Jersey had to change their laws and basically said that you could give buprenorphine post-naloxone or post-overdose reversal with naloxone. We actually modified that criteria and created an additional entry into the pathway where patients who are experiencing withdrawal for any reason, either they're post-overdose and they got naloxone, or they're in what I would call pure abstinence withdrawal. They haven't used for a few days, and they are also feeling all of those same withdrawal symptoms. They can also enter the pathway. We actually talked a little bit about sort of in the early days, creating an overdose receiving center. The idea would be like a trauma center or a stroke center or a STEMI center. This is our greatest public health crisis that we are encountering as a country right now. Why wouldn't we designate hospitals that have the best capability, the most specially trained personnel, and the systems in place to most appropriately take care of these patients? So the concept of the overdose receiving center has morphed a little bit into the concept of the Bridge Center or the Bridge Hospital. And right now in California in particular, we have over 200 Bridge hospitals, some of which have been operating for many years and are incredibly functional. Some are still just getting started. But I wanted to introduce that concept of perhaps taking them to the hospital that might best treat them. And then we also know that if a patient is not transported after an overdose, they have a much higher risk of subsequent overdose. So we have to be aware that it's really important to take care of these patients and to treat them in the field and potentially give them MAT or buprenorphine early on, because we also know that will likely prevent an overdose for the next 36 hours, 24, 36 hours, because it's very long acting. So we've recently updated the buprenorphine guidelines for EMS as of early 2024. So these guidelines have been in place for a couple years now, but what we've done is we've realigned them to more consistently follow the emergency department guidelines from Bridge itself. So there's California Bridge, and the EMS division of California Bridge had a slightly different protocol. But what we've now done is we've aligned the two so that if you are an emergency department provider and you look up the protocols for ED start of buprenorphine, the numbers and the exclusion criteria align very much with the EMS Bridge protocols. And that alignment is designed to have providers see the same patients and see the same pathways, and either they get started in the field or started in the emergency department. So we're going to take a few minutes and actually go through the protocol from the EMS perspective as the treating paramedic, and to give you some training on how that protocol goes. And then we'll give you a QR code and some resources at the end where you can go and learn more. So the first thing we need to do is we need to assess whether there are opioid signs and symptoms of withdrawal. Remember, in the EMS Bridge model, you can get buprenorphine either from post-overdose naloxone withdrawal or pure abstinence withdrawal. And there are both objective and subjective signs. Now, it's really important to separate these two because the objective ones are actually more important. And I'll talk about that right now. We really need greater than or equal to 2 objective signs to be considered for buprenorphine treatment. And that is because the subjective signs, well, they're subjective. And there are many other diagnoses and possibilities for people to display those subjective symptoms. So we really want to focus on the objective signs first. The objective signs are the following: yawning, rhinorrhea or lacrimation, so runny nose or tearing, dilated pupils, tachycardia, diaphoresis, restlessness and or agitation, vomiting, diarrhea, or goose flesh, piloerection. Now, why did we put yawning and rhinorrhea lacrimation at the top? Those are actually incredibly specific for opioid withdrawal symptoms. So we wanted to sort of highlight those first, and so that's why we put them first. But you need greater than or equal to 2 of these to have the patient be eligible for the pathway. In addition, you also look for subjective symptoms, and we'll take both of these into account when we look at our clinical scoring. The subjective symptoms are, as we say, subjective: nausea, abdominal cramps, body aches, achy bones or joints, restlessness, feeling hot or cold flashes, and nasal congestion. And as these are subjective, you could imagine somebody has a really bad case of gastroenteritis. They might have some of these subjective symptoms. So that's why we really wanted to focus on the objective signs and have two or more of those objective signs. Now, next we go to the exclusion criteria. And this is how we've changed our protocols a little bit. The exclusion criteria is to assess whether a patient is not a candidate for buprenorphine treatment. So they have to have opioid withdrawal signs or symptoms. They can't just, they need to have an opioid use disorder, right? So they can't just be at a party and took some substance that accidentally had fentanyl in it. They woke up after getting naloxone from a bystander or from the fire department, and they say, whoa, well, I don't, this is something I don't do on a regular basis. They do not have an opioid use disorder, so they shouldn't get buprenorphine. But if somebody is a chronic user of opioids, then they do have an opioid use disorder and thus would be eligible. Now, we've also changed the age exclusion in California for EMS Bridge. And this is down to 16 years of age. Now, not every EMS agency in California has adopted this, so I want to put out, this is a word of caution or notice to be aware what your local guidelines are. Some counties, some LEMSs have kept the age criteria at 18, and that's totally reasonable. But California law now has allowed the age of consent without parental consent down to 16 for buprenorphine for patients who have, again, a chronic opioid use disorder. Any methadone use within the last 10 days. This is incredibly important because methadone is a long-term binder to those receptors. So if you give somebody buprenorphine who has recently had methadone up to 10 days, you might make their withdrawal symptoms worse. And that's definitely something we do not want. Finally, severe medical illnesses, if they have sepsis or respiratory distress, they are not a candidate, or if they're altered or unable to give consent for any other reason. This is really important. We eliminated, in the prior criteria, we had called out benzos or alcohol, but we want to leave it to the paramedic judgment to determine altered mental status and the ability to give consent. So let's move on. If there are no exclusion criteria present, then you can do a COWS score. If there are, then they are not eligible for a field start. A COWS score, the clinical opioid withdrawal scale, you can pull out your phone and QR code this. The COWS scale is a scale that was developed scientifically to assess how severe the opioid symptoms are. And it's a method for clinicians to measure the level of severity. It's an 11-point scale. You can pull it out on your phone and do a quick calculation and document it in the chart. A lot of the PCRs have it built in now, and so that's super helpful. If it isn't built in, please put it in your narrative. The COWS score, again, determines if the patient is ready to initiate buprenorphine, and it minimizes the risk of precipitated withdrawal. So you check for a COWS score of 8 or equal to or greater than 8. Now, this is another slight modification that we did to our criteria. We used to have a COWS score of 7 or greater. That was the EMS protocols that have been adopted nationwide. However, we really thought about the importance of aligning this with the emergency department guidelines, which use a score of 8. Now, COWS scores are a little subjective, so that may not be a huge difference between 7 and 8. And most of our patients have a much higher COWS score when they get it. Our average COWS score of patients who've gotten buprenorphine starts out at 16. So it's much higher, so it's usually not a problem. So the difference between 7 and 8 probably is almost no patients. However, COWS score of 8 is what we're looking for now. Again, and that's to align us with the emergency department guidelines. So at this point, if their COWS score is greater than 8 and they don't have any exclusion criteria and they meet the other criteria, you can offer the patient buprenorphine. And you can talk to them about other treatment options. Now, another really important, cool thing we did with this criteria is we eliminated the requirement for a base physician call in. Now, the idea is to streamline this process and eliminate one more potential hurdle. If you feel comfortable giving buprenorphine and you feel like the patient is a good candidate, no methadone and none of the other exclusion criteria, then you can give buprenorphine without a physician approval. Now, if you still have questions, you think it's a complicated case, you want to run something by the base hospital, it's totally reasonable to consider base contact for a complex case or additional questions. That's very reasonable. However, if you do feel comfortable giving it and it's in the protocol and you feel like the patient would benefit, you do not need to make base contact. If the patient agrees to treatment, you administer the buprenorphine. We use the 8 milligram strips. They're sublingual films. You put them under the tongue and you give them 2 of those strips. And you can reassess after 10 minutes. If the symptoms worsen or persist, you can redose with another strip. So that's 3 total. Now, after that, if the symptoms improve, it's really important to verify the patient contact information for hospital follow-up or for navigator follow-up. Get 2 contact numbers if you can. Leave behind naloxone. Repeat and document a second COW score to show us how well the patient is improved. We recommend treatment to a bridge hospital if possible, or if you have a bridge hospital in your area. If not, any hospital is reasonable or patient preference. However, we do think that bridge hospitals are slightly better for these follow-up cases. And if the patient, again, declines transport, inform them that maybe a navigator will still try to contact them to see if they need a prescription, a further appointment, or other follow-up. And finally, if you have any other questions, you can use this QR code, reach out to bridgetotreatment.org or emsbridge.org to look at more protocols, and that's where they can be found. Again, I think it's really important to consider this in your armamentarium, and it's incredibly important for us to have this as our possibility. So I want to thank you for your time, and thank you for listening to Dr. Gonzalez and myself. Now I want to introduce Vanessa Lara. She is our fantastic program director here at EMS Bridge and one of our research leads, and she will be talking about motivational interviewing and talk about some individual cases as well. Thank you so much. Take it over, Vanessa.
Thank you, Gene. That was amazing. Thank you all for joining us. My name is Vanessa Lara, and I'm the project manager for EMS Bridge. Today, I'll be walking you through the motivational interviewing for EMS patients. My goal is to help you understand the fundamentals and apply the techniques to each stage of behavior change. Motivational interviewing is a counseling technique that uses a particular style of conversation to talk about change. It ensures that a person's own experience and feelings are considered when seeking to resolve ambivalence during a conversation about change. Motivational interviewing is always directive, patient-centered, focused, and goal-oriented. The style and spirit of motivational interviewing refer to the manner in which the clinician interacts with their patient. The spirit of motivational interviewing encompasses the underlying philosophy and intention behind the clinician's approach. It involves a genuine belief in the client's autonomy, intrinsic motivation, and capacity for change. The spirit of motivational interviewing is characterized by partnership, acceptance, compassion, and evocation. It recognizes that the patient is the expert in their own life and acknowledges the importance of honoring their autonomy and self-determination. Motivational interviewing is a collaborative process. You'll work together with mutual respect and support. As a clinician, it's important to remember to allow space for the patient to voice their own perspective, values, goals, and concerns. As an expert in change, you will approach the conversation with an individual using a lens of curiosity to understand the patient's own experience and feelings about a situation. Showing up for your patients with acceptance means demonstrating positive regard without judgment or criticism. As a clinician, it is your goal and privilege to help others. To successfully use motivational interviewing, you should approach the patient with empathy, compassion, and an understanding that during the conversation, you should recognize the client's struggles, ambivalence, and the challenges they may face in making behavior changes. Compassion helps create a non-threatening and supportive environment for your patient. A clinician should help the patient bring forth the patient's intrinsic motivation to elicit their own reasons and desire for change. Help the patient explore and articulate their own personal motivation and goals, rather than imposing external motivation or judgment. By embodying the style and spirit of motivational interviewing, you can foster a therapeutic relationship that encourages self-reflection, supports intrinsic motivation, and facilitates a positive change. A key component to motivational interviewing is remaining non-judgmental. Interestingly enough, a lot of communication is nonverbal. So consider your body language, your tone of voice when you're having these conversations with your patient. Small changes are really the building blocks of larger behavior change. It's unrealistic to expect an 180-degree turnarounds or complete abstinence at the start of any journey. Instead, implementing smaller changes like reducing the amount used, use of sterile equipment, or carrying naloxone will have a greater impact overall. While these options may not be abstinence-based, they're all harm reduction focused and can lead to future behavior change. This is a scale that depicts where people might fall when they are considering any change in their life. When approaching the conversation about substance use or treatment, make the assumption that every person is ambivalent about change. If the patient indicates they are ready for change, a good resource to use is an action plan. Now, action plans don't have to be fully involved. Working through one step that a patient can take today is enough. If a patient is unsure if they'd like to engage in treatment, use open-ended questions to further explore their feelings. Resistance will happen, and that's okay. By addressing resistance with respect, empathy, and understanding, you may help resolve some of that ambivalence and increase their readiness for change. Now, you've likely already seen these stages of behavior change. But behavior change is rarely a discrete single event. For most people, behavior change occurs gradually over time, with the person progressing from being uninterested, pre-contemplation, they're unaware or unwilling to make a change at this time, to possibly considering change, contemplation, then moving towards deciding and preparing to make a change, preparation, to then following a definitive action plan, and finally making attempts to maintain the new behavior over time, maintenance. And people can progress in both directions in the stages of change. Most people will recycle or relapse through any of these stages of change before the change becomes fully established. Now let's walk through each stage of behavior change a bit more in depth. During the pre-contemplation phase, individuals may still not be aware or not considering making any changes. As the clinicians, this is a time to explore the patient's perception of their health by asking questions. In the contemplation phase, people are starting to question and more closely examine something in their life that they might want to change. Although they may recognize some negative feelings toward a certain behavior, people often feel ambivalent about change in this stage. At this time, you can explore pros and cons with them, highlight people in their life who may be a support system for them. Preparation. During the preparation stage, a person has made the decision to change this time, and this time is often filled with research on change, gathering information, seeking support, or setting specific goals to facilitate the behavior change. As the clinician, this is an opportunity to recognize the challenges and help problem solve and provide positive affirmations. The action stage. The patient is actively modifying behaviors, implementing plan changes, and adopting new habits or practices. Individuals in this stage are engaged, but still require support to maintain their commitment to change. This is a great time to ask a patient about their decision to change and acknowledging any changes that they feel good about. Maintenance. When people have successfully made a change, they enter the maintenance phase. During the stage, they work to sustain the new behavior and prevent relapse. The stage requires ongoing effort, coping strategies, and support to consolidate the behavior change as a long-term habit. Let's discuss change talk. This is any content shared by an individual that leans towards a positive change. The examples on the screen show 4 types of change talk: desire, ability, reason, and need. Keep an ear open for any similar phrases because change talk is a strong predictor of future behavior change. And this can be leveraged to help explore someone's motivation to change. OARS. OARS is an acronym that represents the core communication skills used in motivational interviewing. It stands for open-ended questions, affirmations, reflections, and summary. Open-ended questions are a foundational technique that's often used in de-escalation. They stimulate thought in the patient and allow for exploration of the patient's ideas, feelings, and motivations. Open-ended questions typically begin with what, how, or tell me about. On the left-hand side are examples of closed-ended questions. Closed-ended questions only allow for an individual to answer yes or no. So instead of, do you use heroin? Are you withdrawing? Don't you want to stop? Consider these. What do you use? How are you feeling? Tell me about your feelings about quitting. Affirmations. Affirmations refer to statements made by the practitioner to the patient, acknowledging patient's strengths and wins regardless of the size. Focusing on positive affirmations reinforces the patient's motivation for change. Consider some of these examples of affirmations. I appreciate your honesty. I recognize your commitment. This is hard work you're doing. Reflections involve actively listening to your patient and, like a mirror, reflecting back what they have said. This demonstrates empathy, understanding, and validates a person's experience. An example of this sounds like, patient, it has been challenging to stay sober because of my stressful job, and this is upsetting me. Clinician, I hear that you're finding it challenging to stay sober because of your stressful job, and this is making you upset. Consider some of these reflections. Summaries. Summaries are succinct recaps of larger amounts of information that contain important points made during your conversation. Summaries are useful for highlighting any key information and ultimately closing the loop on that conversation. And lastly, don't forget what really matters. Compassion, empathy, and a non-judgmental approach are the foundations of motivational interviewing and are critical to building a connection to your patients. It's important to recognize that many in this patient population have a distrust of providers due to negative experiences and patient stigmatization. But using the techniques you learned here today will help soften those relationships and build trust. Remember to focus on change talk, listen with curiosity, provide positive affirmations, and lastly, roll with resistance. Now I'm going to pass it back over to Dr. Hern.
Thank you, Vanessa. That was super helpful and a really interesting approach in that it was different than the traditional sort of patient-provider interaction. So thanks again. Now we're going to bring it all together and talk about some case studies. We're going to talk about some real life situations that you may encounter in the field and review some case studies and using that information to determine when and how to use EMS buprenorphine. Now, alone or with a partner, review the following scenarios. Using what you've learned, decide how the call should be handled, from assessment to motivational interviewing and treatment. I want you to consider the following questions too. Is the patient actually experiencing opioid withdrawal? Like they have an opioid use disorder? That's a really important question. And then next, what is the clinical opioid withdrawal scale, or the COWS score? Next, how to assess if the patient is actually ready to try buprenorphine. And then finally, is this an appropriate patient to be administered buprenorphine? Now, I'm going to show you the QR code for the COWS calculator, so get your phones ready. Ready? Here it is. And now let's jump into the scenarios. This is the first scenario. EMS is dispatched for GI, GU, nausea, vomiting. Upon arrival, the patient is a 38-year-old female complaining of abdominal pain, and she's vomiting. She's alert, she's oriented, ×4, and has no other complaints or injuries. The patient states that they're on a prescribed OxyContin, takes 120 milligrams a day, but hasn't refilled the prescription and has been out of medication for a couple days. The patient appears restless, unable to sit still, and she periodically wipes beads of sweat off of her forehead. Her vitals are as follows: blood pressure 136/80, a pulse of 110, temperature is 97.5, breathing at 20, skin is pink, diaphoretic, with a less than 2-second cap refill. The pupils are moderately dilated. Now take a moment and calculate the COWS score. So in this case, the patient has a COWS score of around 15. The patient seems like they're an appropriate candidate for buprenorphine. They have an opioid use disorder, they're in withdrawal, and they have a high enough COWS score. It might be an appropriate candidate, especially because the patient has been out of their prescription for a few days. Next scenario. EMS is dispatched for a possible overdose. Upon arrival, the patient is sitting on a curb with friends around him who report to have administered 4 milligrams of intranasal naloxone after finding him unresponsive. The patient reports he snorted a white powder that he believed to be cocaine. For the patient, he occasionally uses cocaine and has no history of an opioid use or an opioid use disorder. He is alert, he's oriented ×4, and has no other complaints. His blood pressure is 106/80 with a pulse of 82. His temperature is 97.5. He's breathing at 16 a minute. His skin is pink, and he has a less than 2-second cap refill, and his pupils are normal. Now, calculate the COWS score on this patient and determine if you feel like they would be an appropriate candidate for buprenorphine. In this scenario, the patient has a COWS score of 1, doesn't actually use opioids on a regular basis, and doesn't have an opioid use disorder. So in this case, the patient is not an appropriate candidate for buprenorphine. What's our next case? Here's the next case. EMS is dispatched for a tox overdose poisoning. Upon arrival, a man leads you to his 16-year-old daughter who's sitting upright on her bed. The father explains he picked up his daughter from a friend's house the night before without incident, and then 2 hours later, she began to act strange and became unresponsive. He administered 2 milligrams of intranasal naloxone, and she began breathing normally, became alert. She yawns, she frequently shifts in the bed, is becoming irritable as she reports her account of the events. She confides that she's been using pills for over a year and expresses wanting help with quitting. The patient is alert, oriented ×4, and is complaining of nausea. Her pulse is 120, her blood pressure is 146/80, her temperature is 97.5, she's breathing at 18, her skin is pink with a less than 2-second cap refill, but she's diaphoretic, she has goose flesh and piloerection. Her pupils are 6 millimeters and dilated. Now, assess her COWS score, but determine if she is appropriate for buprenorphine in the field, or maybe better to have for buprenorphine in the hospital setting. In this case, her COWS score is probably around 18. But in this case, also, the patient isn't an appropriate candidate for EMS buprenorphine as she is a minor. In this scenario, minors aren't in the protocol yet. There may be a time where that is possible, but at this stage, minors are not candidates for EMS buprenorphine. So you can provide MAT resources, you can use motivational interviewing, and encourage them to be transported to a bridge site or an overdose receiving center. This is the next scenario. EMS is dispatched for GI, GU, nausea, vomiting. EMS arrives to the residence and they find a woman who's lying supine on the couch. Her partner reports she's been complaining of nausea and has been vomiting all morning. She's recently given birth approximately 1 month ago, and that she was given a month-long opioid prescription after her C-section and wasn't provided with any refills. She has no interest in continuing opioids, but doesn't want any quote-unquote drugs. She's not currently breastfeeding and is awake and alert and oriented ×4 and reports no other complaints. She has a blood pressure of 136/80, a pulse of 122, her temperature is 97.5, she's breathing at 20 a minute, her skin is pink, she's diaphoretic, she has a less than 2-second cap refill, and her pupils are moderately dilated. Now calculate her COW score and consider if she'd be an appropriate candidate for EMS buprenorphine. In this case, her COW score is probably around 11. She seems like she might be an appropriate candidate for buprenorphine with this ongoing prescription for the last month, but then abruptly stopped. She's clearly in a withdrawal state. In this case, it might be helpful to use motivational interviewing to discuss the patient options and to help her make an informed decision, in which case she may not choose to do EMS-initiated buprenorphine, but wants to talk with a substance use navigator or a counselor at the emergency department or at the hospital. Thank you so much for listening to our training on EMS buprenorphine and the EMS buprenorphine use project. For everything we've talked about today and so much more, please go to our website, use the QR code. It has patient information, EMS and physician and nursing information, very specific resources at bridgetotreatment.org. So finally, once again, thank you for joining us and being part of this crucial effort. It's not only an important intervention in the opioid crisis, but I think it's also a good intervention in terms of addressing provider burnout and increasing job satisfaction and resilience in the EMS setting. I want to once again thank Vanessa Lara and Dr. Alicia Gonzalez for all of their help with this. Please reach out to the EMS Bridge team if there's anything else you have in terms of questions or to get more involved in this project. Once again, thank you for listening. We really have appreciated your being a part of this crucial effort. Take care.